maybe they'll know.
I was just asking about testing because we're just about to, so we have reception testing, but they're about to start probation testing as well. So
In Hi, everyone. We're going to go ahead and get started. You're in session E, infectious diseases. So if that's not where you want to be, now's the time. Can't hear? Not on? Testing. There we go. Hi, everyone. So you're in session E, infectious diseases. Welcome to the session. We've got some great speakers lined up. My name is Matthew Akiyama. I'm a clinician and researcher at Albert Einstein College of Medicine and Montefiore Medical Center in the Bronx.
And hi, I'm co-chairing today. I'm Monica Desai, consultant epidemiologist at INHSU, so that's the public health agency in England. So I'm just going to do very brief housekeeping before we move on to the presentations, and this is primarily for our virtual audience, so hello to our virtual audience. We're really glad you can join us today. If you'd like to ask any questions during our session today, please submit them through the conference app, and actually that applies to audience members who are here in person as well. To our virtual audience, you can also submit questions via the conference app or type them into the box on the right-hand side of your screen. Please do afterwards visit the INHSU cinema. Sorry, that's later. So I'll pause there, sorry.
All right.
Hand over.
So without further ado, our first speaker is Tommy Brothers, who is a PhD student in epidemiology and public health at University College London. He's also a resident physician training in general internal medicine and addiction medicine at Dalhousie University in Halifax, Canada. He's going to be talking about the social and structural determinants of injection-related bacterial and fungal infections among people who inject drugs, a qualitative systematic review, and thematic analysis. Take it away, Tommy.
Thanks very much. So I want to begin by acknowledging the contributions of the participants in the original studies that I'll be reviewing, as well as colleagues and friends who use drugs for teaching me. And acknowledge that I live and work in Mi'kma'ki, which is the ancestral and unceded territory of the Mi'kmaq people in eastern Canada. And I hold funding from non-governmental and university sources, but I have no relationships with industry. Wrong mouse. So injection drug use-associated bacterial and fungal infections, including things like skin and soft tissue infections, endocarditis, osteomyelitis, are an important problem. Their incidence is increasing in many parts of the world, including places with very different drug supplies, very different policy settings, and to date, individual-level behavioral interventions like educating people on the importance of skin cleaning, hand washing, or avoiding intramuscular injection have been insufficient to reduce population incidence and have had mixed results in interventional trials. And so we argue there's a need to look beyond individual-level interventions to the social determinants of health, which have informed effective approaches to other drug-related harms like HIV and overdose. So the research question for this project was what social and structural factors influence the development, treatment, and outcomes of injection drug use-associated bacterial and fungal infections. This was a systematic review, as was mentioned, and so we applied a conceptual framework, a social ecological model. We used Rhodes' risk environment framework. which emphasizes a few important things in terms of the analysis, that individual behaviors, including injecting behaviors, healthcare access, treatment experiences, are shaped by people's social context. There's an interplay between individual level factors, micro-environmental factors like access to harm reduction services in your community, and macro-environmental factors like broader forces, criminalization, racism. And that individuals as experts in their lives navigate these constraining environments and can work to change their environment, like we see with drug user unions organizing to establish safe consumption sites and change laws around that. For the systematic review, it's part of a broader project, including quantitative and mixed methods studies. What I'm reporting today is on the qualitative part of our search. The participants were any people who inject psychoactive drugs. The exposures, we tried to be as broad as possible, trying to include anything that might affect risk for infections or influence their treatment. And the studies had to describe participants' experiences of these outcomes, so the incidence, treatment, or outcomes after an infection. We searched 5 databases, developed our search strategy in consultation with a librarian, and searched from 2000 to 2001. And the analysis itself, we followed a process known as thematic synthesis. You can see the reference from Thomas and Harden there. It involved line-by-line open coding of the qualitative and qualitative parts of the mixed methods papers, identifying descriptive themes across the studies, and then translating these descriptive themes between studies, organizing them into conceptual categories to identify higher order themes. And this process is focused on the interpretations and conclusions of the qualitative study authors, because Thomas and Harden argue we can't sufficiently know the original qualitative data to take, for example, participant quotations out of context. So the unit of study is the qualitative papers themselves. The review team brought in diverse perspectives, which I think was a strength of the project. Initially, myself and Matt Bond, who might be in the audience, who was speaking earlier on the panel, did the open coding of a few selected studies. And then the whole team would meet online and review the themes and candidate themes and codes and do some collaborative online writing to develop the framework. We found over 4,000 titles. The broader search identified 150 eligible studies. And what I'm reporting on today is the 26 studies that had qualitative data. Most of them were conducted in North America. Most of them involve skin and soft tissue infections, which by prevalence are by far the most common type of bacterial infection. And only one study out of the 26 considered fungal infections. So our results focus primarily on bacterial infections, which are also more common. This is a brief overview of the themes that we identified and developed, and I'll go through each in detail and provide some examples, quotations in a moment. But just to briefly take you through it, the first 4 descriptive themes on the left are the main forces, the main social structural factors we identified as influencing risk for infections or influencing their treatment. So the unregulated drug supply people were accessing, they describe things like poor solubility or adulterants leading to vein damage, development of abscesses, having to use too much acidifier to dissolve drugs, unsafe spaces like being unhoused, not having clean and hygienic places with running water to prepare drugs, and once injecting outside, having to compromise their safe injecting practices to avoid the police. Theme 3 was negative health care policies and practices, like experiences of discrimination, untreated pain, and withdrawal that pushed people away from accessing care or made them leave hospital before their treatment was done. Limitations on harm reduction programs, like inadequate funding, limited effectiveness. And we grouped those as an analytic theme, considering the social production of risk. So trying to identify how the broader forces like stigma, criminalization, mandated abstinence in healthcare settings actually contributed to risk for these infections. And the 5th and 6th themes there on the bottom left, mutual care and self-care. We found descriptions of how people who use drugs prevent infections, treat their own infections, promote their own health, while operating within this risk environment of all of these harmful social and structural forces around them. And I'll show you some examples of that. So the unregulated drug supply, as I mentioned, lots of people, there was lots of reports within the qualitative studies of people who use drugs attributing their infections to the poor quality of the unregulated drug supply. And here's a quotation from a participant in Denver, Colorado. "I think it's the dope. I'll use a clean needle every time, and still it just depends on what they cut it with. Sometimes when you're cooking it, it's an okay color, and the next time you're doing it, you've got all this shit floating up, and it's all burnt around the sides." And this was specifically asking this person to explore where their infections were coming, their bacterial infections were coming from. For unsafe spaces, the influence of being unhoused, the lack of safe and hygienic space, running water, adequate lighting to prepare drugs or find veins. From one of Magdalena Harris's papers, a participant in London, there was no running water, and I actually had to use a bit of saliva, and this was to dissolve the drug solution to prepare it for injection. It worked. I still got my hit, but I also got the worst infection of my life. I nearly died. I was in hospital for nearly 3 months, septicemia. So in some places, harm reduction programs are obviously distributing ampules of sterile water, and where that's accessible, that's wonderful. But if people can't access that every time and they don't have access to running water or bottled water, then of course people have to use alternatives. Saliva is a bit of an extreme example in this work, but descriptions of using puddle water or soda were more common. Also related to unsafe spaces, once people were injecting outdoors, they were vulnerable to policing practices, and this could influence how they prepared and injected drugs and make them more likely to muscle their shot and get an abscess. So this description from Philadelphia, I don't even use a cotton filter, and boom, I get it done like that. So if the cops raid, and several times the cops have pulled me over, come right up to me, and I've already injected it in my arm before they hit me. So in this case, the fear of the policing practices has led this person to skip what would be otherwise their safer drug preparation practice of using a cotton filter, but instead they're just muscling their shot. Negative healthcare policies and practices, as I mentioned, experiences of discrimination, undertreated pain and withdrawal, discouraging access to care. Here's a description also from London. Magdalena wrote, Kirsty fears what might have happened if she doesn't attend hospital for an injecting-related injury, and the participant quotation in italics, could turn into blood poisoning, you can die, I don't want to die, I've got children. But for now, she will not seek care. She explains why. Like scum, isn't it? Of course you're going to get treated like that. It's obvious that they're going to treat you like that if you're on drugs. It's horrible, really, because you're scared to tell them that you inject. So in many of the papers, people were describing having a superficial infection and having no intention of seeking health care because of how they'd been treated there before, or seeking care and being denied pain medication or being denied OAT. And leaving hospital before it was done because, of course, they felt so unwell. Self-care included strategies to prevent or treat bacterial infections within the constraining risk environments. So participants described staying hydrated, rotating injection sites to maintain vein patency and vein health, self-treating abscesses if they felt unsafe accessing traditional medical care, like incision and drainage, non-medical sources of antibiotics from friends. And there were several descriptions of people injecting into the groin, which is obviously a high-risk area for arterial injury and thrombosis, so that they wouldn't have visible scars when they were wearing t-shirts or shorts, and they didn't want to disclose themselves as a drug user. So when trying to navigate this risk environment, obviously some of these self-care practices to avoid bacterial infections or their sequelae have huge trade-offs in terms of other health risks. Little things like drink a lot of liquids, make sure you sleep every night, make sure you get enough sleep, eat regularly, these are key points. Mutual care, helping each other avoid infections or avoid the complications of infections. Strategies like education or advice from fellow people who inject drugs, especially in places where there weren't robust harm reduction programs doing this education. Sharing sterile needles and injecting equipment, again, when people didn't have access to enough. Or community-based wound care, abscess treatment, and antibiotics outside of traditional medical settings. And finally, seeking injecting assistance from someone in your community if you can't successfully access your vein to, again, avoid intramuscular injecting. And there's real trade-offs and health risks here, especially if people are in gendered power relationships where they might not have control over that injecting assistance. I have a boyfriend, I only hit with him, always with him. I do not like to do it with strangers or people whom I don't know so well. My boyfriend helps me because when I do it, it swells up or goes outside the vein and can contribute to an abscess. And several of the papers explored and discussed these trade-offs within risk environments. So strategies to avoid or reduce bacterial infections precipitating other health risks, HIV transmission from assisted injecting when people can't access their own vein, arterial injury from groin injecting when they want to hide a wound or an abscess in a more peripheral site, and resistant infections or chronic wounds when people are using inappropriate antibiotics from non-medical sources when they don't feel safe accessing medical care. And this is just one of the considerations from a study of sex workers in San Francisco in 2002 who use drugs. Abscesses and scars are more frequent with muscle injection, but they deteriorate the women sex workers' precarious strategies of income production. Although being injected by another increases the probability of HIV infection, it simultaneously prevents the physical damage that subjects these women to greater vulnerability that comes from abscesses and associated scars. So in conclusion, from all of this, injecting-related bacterial and fungal infections are shaped by modifiable social structural factors, including poor quality of the unregulated drug supply, criminalization, insufficient housing, limited harm reduction services, and harmful healthcare practices. And of course, all of these are modifiable to one degree or another and have been in many places. And that enabling environment interventions, like providing a regulated supply of drugs, decriminalization, housing first, that address these factors could further empower people who inject drugs to protect themselves and their community. We do have the full manuscript draft available as a preprint if anybody wants to read about this in more detail and see many more examples and discussion. And thank you very much.
Thanks so much, Tommy. So if anyone has any questions, you can type them into the app or come up to the mic. There are mics on both sides of the room. To start us off, Tommy, great study, really interesting methodology. In terms of, you've identified some of the issues and challenges and perceptions people face. In terms of interventions, what would you suggest we do for bacterial and fungal infections to help mitigate them among people who inject drugs?
Yeah, that's a great question. And part of my interest in this like I'm a clinician as well. And I think, we're going to hear about today, there's lots of innovation about integrated treatment models and trying to combine infection treatment with addiction treatment and harm reduction services. But what I found really interesting about this project was thinking about in a less medicalized way, like what are all of the things outside of people's lives besides their medical care that's influencing risk for these infections. So, with the unregulated drug supply, like many people in heroin-assisted therapy or injectable OAT end up muscling their shot but don't get abscesses because it's sterile pharmaceutical-grade drugs in a hygienic environment with sterile equipment. In places where there is decriminalization, when it's done right, obviously people don't have to be hiding from the police and muscling their shot and rushing their injecting practices. So I think the interventions in this case are much more about policy, economic, activism factors than they are about the medical model. But there's lots of lessons and examples in the manuscript about how we have to change hospital policies and healthcare policies to acknowledge and support that people are going to be using drugs today if they were using drugs this morning before they came into our clinic. So withdrawal management, safe injection sites in hospitals, all of that kind of stuff.
Absolutely. Thank you so much. So we're at time. I think we can move on to our next speaker.
Thank you.
Thanks, Tommy.
Thank you. So our next speaker is Professor Peter Vickerman. Peter's a professor in infectious disease modelling with over 25 years' experience in infectious disease modelling. His research focuses on using modelling to help understand the transmission of infectious diseases and the impact and cost effectiveness of prevention measures amongst key populations, especially HIV and hepatitis C. Thanks.
Thank you, and thank you for inviting me to, well, not inviting me, but allowing me to talk on this subject. So what I'll be looking at today is a study we've been doing over the last year and a half, looking at estimating the incidence and trends in HIV incidence amongst people who inject drugs in Kachin province in Myanmar and trying to understand whether there's evidence for the impact of interventions. So Myanmar is the second largest opium producing region globally, with the main regions where it occurs being in Shan and Kachin state, as you can see in the cursor there. In this region, injecting drug use is very common, partly due to the high production of drugs, but also there's a strong link with mining, jade mining, which occurs in the region. The region is also rather chaotic and turbulent. So there's ongoing conflicts there between the Myanmar government and the Kachin Independent Army, and that's been ongoing since 2012, and there's been a lot of internally displaced people. And the HIV prevalence amongst people who inject drugs in this area is very high, at over 40%. So there are interventions in Myanmar. Needle and syringe programs started in 2003. Opioid agonist therapy started in 2004. And HIV treatment is also available. And these three figures show national data for how these interventions have all scaled up since the early 2000s. Medicine du Monde has been running harm reduction projects in Kachin since 1996, and they have 3 drop-in centres in Kachin state. These drop-in centres and outreach interventions provide needle and syringes, opioid agonist therapy, HIV testing, and HIV treatment. And these interventions have also scaled up over time in a similar way to the national scale-up. So what we wanted to do is to use data from these 3 harm reduction interventions in Kachin to look at the HIV testing data to develop a HIV incidence cohort of people who inject drugs people who use drugs and their sexual partners, basically all the people that attend those harm reduction drop-in centres. We wanted to use that incidence cohort then to look at to investigate trends in HIV incidence over a 12-year period from 2008 to 2020. And because they also collected data on other factors and we were able to link to intervention data, we wanted to see what factors were associated with HIV incidence amongst people who inject drugs, and especially looking at the contact with OAT and the coverage of needle and syringe programs. So the drop-in centres in Kachin are in 3 places called Hopin, Mogan, and Michkina, which I have difficulty pronouncing. And generally, people are HIV tested at their first visit at enrolment, and then they are periodically retested if they were initially HIV negative. Over the period 2008 to 2020, they had 20,761 people were HIV tested. And the pie chart in the top right gives the distribution of who was tested at those interventions. The red region shows that most of the people tested, about 68%, were people who inject drugs. However, there was also a significant group of people who use drugs but don't inject them, and also partners of people who inject drugs and people who use drugs that attended the interventions. The HIV prevalence of the different groups tested is shown in the figure to the bottom right, with the HIV prevalence unsurprisingly being highest amongst people who inject drugs at 48.3%. But lowest in the general people that say they're from the general population at 2.3%. You also see that the other groups, such as people who use drugs or the sexual partners of people who use drugs or who inject drugs, having a prevalence of between about 12 and 16%. The HIV prevalence was similar across the 3 drop-in centres. So what we did, we used this HIV testing data set to link HIV test results, and we were specifically interested in those who initially tested HIV negative, and then of those who received at least 1 additional HIV test. This allowed us to capture instant HIV infections, but also to track person years of risk, and that's how we created a large HIV incidence data set. Medicine du Monde at each HIV test also has a standardized form that collected information on sex, age, the population risk group, but also basic injecting and sexual risk behaviors. And these vary over time. And so this allowed us to associate behaviors and risks and ages to the HIV testing data. We were also able to get intervention outcome data as well, specifically individual OAT uptake, but this was only available in 2 of the drop-in centres that provided that intervention. And we were also able to get monthly needle and syringe provision coverage for each drop-in centre over 2012 to 2020. And with the incidence cohort, there was 2 main things that we wanted to do. Firstly, within the whole incidence cohort, we wanted to look at how incidence differed by the different population risk groups, such as people who inject drugs or people who use drugs and their sexual partners, and also what was the difference in incidence by sex or gender. And then within the subset of that cohort of just people who inject drugs, we wanted to look at what demographic risk factors in intervention contact variables were associated with HIV incidence, and we undertook 4 Cox regression models to look at this. Now, it's important to give a little bit more detail on the exposure variables that we used for the interventions. So for OAT, we had 4 different categories which we put people into, depending on their OAT status. Firstly, we had people that are currently on OAT, and then for those that are not currently on OAT, we split it into 3 categories. Those that are never on OAT during the whole follow-up period, those that are not currently on OAT but will be in future follow-up, or those not currently on OAT but have been in past follow-up. And the reason we use those 2 last categories is to try to understand whether people inject drugs that do go on to OAT, whether they have differences in risk irrespective of being on OAT, to understand whether OAT amongst that group decreases their risk, and when they come off it, their risk increases. Now, for needle and syringe provision, we didn't have that at the individual level. We only had that as a number of syringes given out each month for each drop-in centre. And what we did, we categorised each 6-month period for a drop-in centre as either low, medium, or high needle and syringe provision coverage. And this was defined as either the needle and syringe coverage being lower than the quartile distributed on average in each 6-month period, or above the upper quartile of what's distributed in each 6-month period, or in between those two quartiles. Now, for the regression models that included OAT or NSP, because we didn't have OAT status for all 3 drop-in centres, and we didn't have needle and syringe coverage data for the whole time period, they weren't both in all the regression models. But when we had OAT in a regression model, we didn't include recent injecting in that regression model, and that's because we saw recent injecting as a mediator for the impact of OAT. And when we had NSP in a regression model, we didn't include recent syringe sharing in that model because we saw that as a mediator for the impact of needle NSP. So this presents some of the basic results from the incidence cohort. So firstly, in the HIV testing database, we had 13,057 individuals that initially tested HIV negative. And then within them, we had 3,685 that had a further HIV test, and those people make up the incidence data set. Within the incidence data set, those people had on average 2.7 HIV tests over a median follow-up of 2.4 years. And we had, in total, we had a follow-up of 8,976 years with 473 incident HIV infections over the 12-year period, with 94% of those HIV infections being amongst people who inject drugs. Now, if you look over the whole incidence cohort, we got an incidence of 5.3 HIV infections per 100 person years over the whole 2008 to 2020. If you looked at amongst people who inject drugs, the incidence was higher at 7.1, whereas it was lower amongst people who use drugs at about 1 per 100 person years, and it was also lower amongst sexual partners of people who inject drugs or people who use drugs at 1.1 per 100 person years. We also found that incidence was higher amongst men than women, but that's mainly due to most of the men in the overall cohort being people who inject drugs, and most of the women being sexual partners of people who use drugs or people who inject drugs. So this presents some of the main findings from the study. So this is sort of just looking at the HIV incidence in different subgroups of people who inject drugs. Just as a reminder, we found that the overall incidence of people who inject drugs was 7.1 per 100 person years. Now, if you look, we looked at in different time periods, and if you're looking at the incidence estimates in this red square, you find that incidence decreased dramatically over time. So it decreases by about 75% over the period from 2008 to 2020, with the incidence in the first time period being 19.3 per 100 person years, and in the most recent time period, it being 5.2 per 100 person years. Now, recent behavioural risk was also associated with increased incidence, and recent is measured as in the last 6 weeks. So if they had unsafe sex in the last 6 weeks, then their incidence was 9.2 per 100 person years. If they recently inject drugs, then it's 12.2. Recently syringe shared, then it was 18.7. And most dramatically, if they recently initiated injecting in the last 2 years, their incidence was 30 per 100 person years. Importantly, though, we also found that interventions were associated with reduced incidence. So in periods where a drop-in centre had high coverage of needle and syringe programs, the incidence was 4.1 per 100 person years. Whereas if somebody was currently on OAT, then their incidence was 3.1 per 100 person years. And interesting, when you look at the OAT states, we found that for those people that are not going to be on OAT but not currently, or have been on OAT but aren't currently, they had a similar instance to those people that are never on OAT. So this we looked at the relationship between incidence and coverage and needle and syringe programs in more detail. And what we found across the 3 drop-in centres over the whole period, that needle and syringe, the coverage of needle and syringe programs was inversely correlated with HIV incidence, as shown in this figure here. So basically, as you distribute more syringes, your incidence decreased in a sort of linear fashion to quite low levels, or very high levels if you were not distributing many syringes, which we thought was a rather nice result. And then when you look at, we also undertook adjusted regression models. So this only presents one of the models, which looks at just 2012 to 2020, and just 2 of the drop-in centres. And this is the period and the drop-in centres where we have data on NSP and OAT. And this model doesn't include recent injecting or syringe sharing because we saw those on the mediators for OAT and NSP. And what we found here was, again, HIV incidence still decreases over time by about 11% per year. We find that HIV incidence is much lower if you're injecting greater than 5 years compared to injecting less than 5 years. So it's 80% lower if you're injecting greater than 5 years. And we didn't find any difference by site in terms of HIV incidence or between males and females, although the incidence amongst females is highly uncertain because there was very few female people who inject drugs. Importantly, we still find the interventions associated with reduced incidence. So if you're in a period of high coverage needle and syringe provision, your incidence is 36% lower. Whereas if you're currently on OAT, then your incidence is 63% lower. Ooh, 1 minute. Okay. The other regression models gave similar findings. So in conclusion, HIV incidence is very high in Kachin province, but evidence suggests that it has decreased over time. Our findings suggest that interventions have reduced incidence by quite dramatically, by 63% if you're on opioid agonist therapy, and 36% if you have high coverage needle and syringe provision. It's important to note that this is the first evidence of the impact of those interventions in a low and middle income country setting. Other evidence in systematic views has all been from high income or middle income countries. But it's interesting to see that the estimates are comparable to data from those high income countries. It's also important to note that our additional characterization of OAT suggests that the impact of OAT is due to people accessing that intervention, not due to those people having lower risk and accessing OAT. Now, the intervention impact may partly explain the decrease in incidence, but we still saw a decrease in incidence in the adjusted model, and this could be maybe due to the effect of the scale-up of HIV treatment, which we couldn't include in our analyses. Ooh. Also, incidence is very high in new people who inject drugs, and interventions need to prioritize this group. And then I put a load of things there about how we should use these routine data sets for doing things elsewhere. And that's to acknowledge all the people involved in the project.
Thank you, Peter. I'm afraid we're out of time for questions, but perhaps you can catch Peter later for questions.
Okay.
So our next speaker is Tanya Schwartz. Tanya is a researcher in the field of drug-related epidemiology and addiction at the Austrian Public Health Institute. She's involved in various national and international projects on illicit drugs, substance use, and resulting health consequences, drug-related infectious diseases, and mortality. Take it away, Tanya.
Thank you. All right, thank you for the opportunity to present our work on models of good practice today. I'm here on behalf of my wonderful colleagues Ilonka Horvath and Ottilia Mort, who is also in the audience today. We conducted, or the background of our work was conducted in the framework of an ECDC and EMCDDA guidance update. The guidance was published on prevention and control of infectious diseases among people who inject drugs in 2011 and is now updated and in press. And our analysis therefore utilizes the models of good practice that we collected in this framework. This was commissioned by the ECDC to GERC, to the Public Health Institute where I'm working, And we aim to support the guidance update by identifying models of good practice that improve community-based testing, as well as linkage to care and adherence to treatment for infectious diseases among PWIT. Models of good practice were defined in our framework as interventions or a package of interventions with proven effectiveness in certain settings and which are likely replicable and sustainable in other settings or countries. We looked at hepatitis B and C, also on HIV and tuberculosis, and we looked at the geographical coverage, included the EU and EEA countries, the UK, the ENP area, and the Western Balkans. So our general aim was to add practice-based evidence derived from interventions that were implemented in real-life settings and first and foremost also with a documented impact. So we are also building upon our previously published work, which was a literature review that also looked at interventions on linkage to care and adherence to treatment. And there we found that there is rather limited evidence on interventions implemented in European settings and very limited information on enabling factors and what makes those interventions successful. We formulated 2 research questions. First is which interventions were employed in the models of good practice by stage of the care cascade and what are the main implementation characteristics, and which were the overarching enabling factors inherent in implemented interventions. For our systematic collection and selection process of the models of good practice, we first initiated a call of expression of interest that was sent to several experts and networks in many countries. The submissions were then guided by an online reporting form, and the experts and networks were invited to submit their models of good practice in between September and October 2020. A set of predefined criteria guided the selection process. So for the pre-assessment, we examined the models of good practice with regards to the inclusion criteria. This really was to evaluate the adequacy of the intervention, and core criteria, where we looked whether the intervention was successful and had a documented impact. We identified a total of 17 models of good practice that were then assessed by an international expert panel, which was conducted by the EMCDDA and ECDC. They looked at factors like transferability or sustainability or stakeholder participation, which led us then to 15 submissions that were selected as models of good practice, 6 for testing, 5 for linkage and linkage to care, and 4 for adherence to treatment. After identifying the 15 models of good practice, to answer the first research question, we looked at, or we identified the structural characteristics such as countries and geographical coverage, the infections targeted and the settings. But we did also, or we conducted an in-depth analysis of the interventions employed within the models of good practice for every stage of the care cascade. For answering the second research question, we looked at the enabling factors. Those were extracted from the narratives that were reported by the submitters of the 15 models of good practice, and we clustered them for each stage of the care cascade. The 15 models of good practice were implemented under 10 framework programs. Most of them were addressing several infections and also several stages of the care cascade. The geographical coverage has been quite wide. We gathered evidence also from Eastern European countries, and we also identified a variety of settings. So most interventions were again implemented in more than one setting and included, for example, harm reduction services, outreach programs, outpatient drug addiction treatment centers, OAT settings, but also prisons and pharmacies. So across all stages of the continuum of care, decentralization of specialized services was indicated by all models of good practice and included outreach and low-threshold screening for infections, for example, and screening free of charge. The integrated services followed a I think it's in the brownish. The integrated services followed a one-stop shop approach. They included multi-professional teams, screening, medical supervision, public health, as well as social support, and were sometimes combined with OET setting or outreach work. Cooperation was also considered a very effective intervention in the models of good practice, and was set between low threshold services and local hospitals, primary healthcare centers, and also social institutions. Further, peers have an essential role in the analyzed models of good practice. They acted as facilitators for interacting with and building trust in provided services, and were involved in peer-to-peer trainings, in point-of-care testing, and also in the use of FibroScan, for example. With regard to the second research question on factors acting as enablers of interventions, we did a synthesis of the enablers to provide kind of an insight in specific factors that really have a proven impact on interventions. And a facilitating factor over all stages of the care cascade was the preparedness of the care environment. What do we mean by that? It kind of facilitates the cooperation among service providers, or it shall facilitate it, and that there's a functional connection between the main actors in this field. So low threshold services, but also local authorities, politicians, medical and social institutions. Also very important, the lack of legal constraints in terms of a general political consent and a political will to provide treatment, and also harm reduction services and harm reduction and low threshold services to PWIT. Peers were mentioned in our study in a double function, so as intervention to optimize the progression of PWIT through the care cascade, as I already said, but also as enablers for the individual stages. A last point was the well-established relationship of trust between service providers and PWIT that mostly resulted from long-term contacts, and they are, this was described as the foundation of most interventions. So I want to dive right into the conclusions and take-home messages. So the interventions have been designed mostly to really address the very unique patient, provider, and system level barriers. The models of good practice also demonstrated that the combination of interventions and the involvement of multiple sectors of service provision are successful, and also for multiple infectious diseases. Results also highlight that care structures and pathways, or treatment pathways, should be simplified, mostly through reducing complex testing and treatment pathways. They should also be based on cooperation, rather on one hand on within the facility, or external with facilities that are in collaboration with services that PWIT are already accessing. And they should be multidisciplinary and may comprise healthcare professionals, social healthcare workers, and experienced outreach workers, trained peers, and more. Preconditions then influence the success of intervention. Intervention should include a policy-level commitment from local national authorities' side. There should be no systemic barriers to the infectious disease treatment for PWIT. That could be like ensuring funding, and that there should be treatment free of cost. The preparedness of care structures is another important point that includes, for example, the existence of staff that is really sensitized to assist PWIT and to deliver a supportive work. Also valuable are existing collaborations between the service providers already at facilities that are already working in this field, like pharmacies that are already involved in the OET should be included here. And looking at the social dimensions of enablers, there's sufficient qualifications of providers and peers that get into contact with PWIT. That is a relevant part to really address PWIT groups' lived realities and really their particular needs. So in light of often very limited information on or description of success factors or enabling factors in the peer-reviewed literature, we are calling for more qualitative research on implementation practices and experiences. this could be also like in large-scale comparative studies, and we want to, or it is important to gain further evidence from valuable practice-based experiences that really support the improvement of PWID inclusion in the treatment cascade. Last but not least, I want to quickly call attention to tomorrow's shared session with ECDC and EMCDDA on the new guidance update on prevention and control of infectious diseases, which takes place tomorrow, and there we will discuss everything in more detail. My contact, and I think I have acknowledgements. Yeah, thank you so much.
Thank you, Tanya. So we have 2 minutes for questions. Please keep them coming through on the app, or please come up to the mic if you have any questions. I have a question. We so often see the care cascades divided by infectious disease. What made your group decide to collapse all of the infectious diseases together in one analysis? And did you see differences between infections?
Sorry. No, thank you for this question. So we really, for the systematic review, we divided the infectious at first. We didn't divide it, then we really, I don't know, we've seen that it's, that the evidence base is really bad for tuberculosis, for example, for hepatitis B and HIV, so really focus on hepatitis C in the end. And for this models of good practice collection, we had the feeling also for the expert panel and also for reading through the models is that it doesn't have to be really particular to the infections. This is something that really is, I don't know, I'm kind of missing English at the moment, but yeah, it doesn't have to be infectious disease really specific.
Okay. I think we have time for one question over there.
Hi, it's Matthew Bond from the Canadian Association of People Who Use Drugs. More of a quick comment, great presentation. And just something that was shared with me actually at my first INHSU is that you don't, when saying PWID, actually say people who inject drugs, because it takes away from using the person first language. So you're kind of like labeling people as PWIDs instead of actually saying people who inject drugs. So just a comment.
No, thank you. Yeah, that's a good comment.
Thanks, Matt. And thanks so much, Tanya.
Thank you.
Okay, so our next presentation is from Dr. Sarah Katakushi. Sarah is an academic clinician investigator who has expertise in the syndemic of hepatitis C and OUD. She's an associate professor in the Institute of Human Virology at the University of Maryland School of Medicine, where she serves as co-director of the research initiative in infectious diseases and substance use. Over to you, Sarah.
Thank you. And I'm your first 5-minute presentation, so buckle up, everyone. So I'll just move right into the presentation. Here are my disclosures. And I'd like to begin by acknowledging and thanking the people who inject drugs community who've generously participated in our research and who are really the inspiration for all the work that we do. So as my colleagues before me have beautifully pointed out, given the rise in infectious complications of opioid use disorder, hospitalization and transitions from inpatient care to outpatient care remain critical touch points in the healthcare system. So this qualitative study aimed to analyze the major barriers and facilitators to transitions of care for hospitalized patients with opioid use disorder. So the CHOICE investigation is a multi-site collaboration across 4 U.S. academic medical centers with high regional overdose mortality. Semi-structured interviews were conducted with 24 expert stakeholders with relevant professional experience as healthcare providers, harm reductionists, and/or public health and nonprofit workers. De-identified transcripts were coded using qualitative analysis software, and thematic analysis involved both a hybrid deductive and inductive approach with creation of both within and between site themes. 7 key themes were identified across the 4 sites, depicted here with some relevant quotations, including, of course, as been mentioned many times today, stigma, limited communication, the lack of standardization in practices, limitations in resources, the need for a harm reduction approach, the constraints of the environment, and the urgent need for policy and advocacy. Stigma was the primary constant across all respondents and permeated all aspects of care, from judgment around the use of medication for opioid use disorder to presumed criminality. Harm reduction in the context of transitions of care was defined as centering the patient experience with an emphasis on co-located services and addressing social determinants of health. The lack of standardization in medical practice, particularly around hospital-based opioid use disorder care provision, was cited as a recurrent challenge. Unclear policies and variability in practices were felt to be rooted in both a lack of knowledge on the part of providers and perpetuated by learned helplessness. These core thematic findings were also organized around a socio-ecologic framework, which placed each theme in a relevant sphere of influence, ranging from the individual to national. This framework was useful in identifying potential targets for future interventions. So, for example, stigma was identified as a barrier at multiple spheres of influence. So at the individual level, targeted interventions around provider education are critical, but at a US national level, aggressive legal and policy change is required to dissociate criminalization with people who use drugs. So in this multi-site investigation, major barriers to care for hospitalized patients with opioid use disorder included a lack of standardized protocols, impaired communication, limited investment, and overwhelmingly stigmatization. And the socio-ecologic framework emphasized that interventions must cross multiple spheres of influence and involve a multidisciplinary approach in order to have scalable impact. So without deliberate efforts to ameliorate gaps in the opioid use disorder care continuum, the opioid epidemic in the US will continue to escalate. Evidence-based practices and common sense policy must be prioritized, invested in, and standardized. And with that, thank you.
Thank you. Please do send questions in on the app or use the microphone. But just to start with, I wondered whether what your plans are for informing any changes in policy and practice based on your research.
Absolutely. We'll have actually a corresponding quantitative paper out coming soon. But one of the main, there were two main findings in both the quantitative and qualitative aspects, and that's this lack of standardization around initiation for medication of opioid use disorder when patients present with complicated infections. There's not a one-size-fits-all approach, as many of these patients require acute pain medication, have prolonged hospital stays, etc. But that lack of standardization is something that each of the hospitals really decided that there needs to be an existing policy in place.
Thank you very much.
Thanks, Sarah. So our next speaker is Sotirios Roussos. I hope I pronounced that correctly. Sotirios is a PhD candidate in the Department of Hygiene, Epidemiology, and Medical Statistics at the National and Kapodistrian University of Athens. His main research interest is in infectious diseases, especially among people who inject drugs.
Thank you very much. Good afternoon, everyone. I'm going to present our results about HCV and HIV transmission during the COVID-19 pandemic among people who inject drugs in Thessaloniki. Let me introduce what we know about Thessaloniki. Thessaloniki is the second largest city in Greece with over 1 million inhabitants, and the population of people who inject drugs was estimated approximately at 1,200 in 2016. Among people who inject drugs assessed on drug treatment programs in 2018, the HIV prevalence was 57%, and HIV prevalence was under 1%. Our study aims to estimate levels of HIV and HIV transmission in people who inject drugs in Thessaloniki during the period 2019 till 2021. In September 2019, a sick test treat community-based program was implemented under the name Alexandros in the center of Thessaloniki in Greece. Responder-driven sampling was used in order to recruit participants in 5 consecutive RDS rounds. In total, 1,101 unique participants were recruited, and 35 of them participated in multiple RDS rounds. Tests for HCV and HIV, as well as interview and linkage to care, were included in the participation procedure. These are the 5 consecutive RDS rounds in time-specific period, along with the exact number of participants. Individuals could participate in multiple rounds, but only once in each round. To estimate prevalence, we took a positive test at any participation, and to estimate HCV and HIV incidence, we analyzed 131 participants and 379 initially seronegative participants with at least 2 available samples respectively. The seroconversion time was estimated as the midpoint between the last negative and first positive test date. Now let's look at the participants' profile. As we can see, the mean age of participants was 40 years. The majority of them were men without social insurance and with Greek origin. More than half were active users, with injection in the past 30 days. 15% were currently homeless. Only 5% had received free syringes in the past 12 months, and 20% were currently on opioid substitution treatment programs. The HCV prevalence was 63%, and during the follow-up, 18 seroconversions occurred, which corresponds to 16 new HCV cases per 100 person years. The HCV prevalence was 7%. In 387 person years of follow-up, 27 seroconversions occurred, which corresponds to 7 new HIV cases per 100 person years. In conclusion, Alexandros was successful in reaching rapidly large number of people who inject drugs most in need, despite the difficulties posed by the COVID-19 pandemic. We documented the high levels of HCV transmission. Globally, the pooled HCV incidence was 14. Also, we documented a high HIV incidence. Globally, the pooled incidence of HIV was 1.6. And during the HIV outbreak in Athens in 2012, incidence was 7.8. And the following period, 2014 till 2022, the incidence was 1.9. So these levels of HIV incidence indicating the emergence of an HIV outbreak that coincides with the COVID-19 pandemic and the implementation of social distancing measures. Thank you very much for your attention.
Thanks so much, Sotiris. That was really fascinating. What do you hypothesize is the mechanism between social distancing and these outbreaks of HCV and HIV? What do you think was happening?
Can you repeat your question?
I'm just wondering what you think the mechanism is, the link between social distancing and the outbreaks of HIV and hepatitis C that you witnessed in that region.
Okay, I'm not sure if I understand the question, so we can discuss further in the break.
Okay, that sounds good. We're actually out of time, so that works well. So we'll move on to our next speaker.
Brilliant, thank you. So our next speaker is Dr. Oluwaseun Falade-Nwilia. Sorry if I've mispronounced your name. Oluwaseun is an associate professor at Johns Hopkins University in Baltimore, Maryland, USA, and her research focuses on understanding the distribution and impact of hepatitis and HIV infections and treatment on outcomes for people who inject drugs, and the use of implementation science approaches to improve hepatitis C, HIV, and drug use treatment for people who inject drugs. Thanks very much.
Thank you for the introduction. I'm excited to present our work on behalf of my colleagues at Johns Hopkins. The opioid crisis has led to increases in HIV, hepatitis C, and other infectious diseases. In the US, any provider with an X waiver can prescribe buprenorphine in office-based opioid treatment. Models of care to integrate substance use disorder care into infectious disease care are needed, especially because ID providers continue to report limited knowledge, comfort with, and support for substance use disorder care as barriers to integration of substance use disorder care into their work. The RESTORE program utilized a multi-component approach to address these barriers. Our setting is the Johns Hopkins John G. Bartlett Infectious Disease Clinic, which is a large clinic that provides infectious disease care to over 5,000 patients per year. Our implementation strategies included training of providers through on-site buprenorphine waiver training and access to online substance use disorder training models. Providers had the opportunity for ongoing consultation through substance use disorder care didactics and case discussions, and received local technical assistance from an ID provider that was supported to learn more about providing substance use disorder care, treat patients directly, and then provide support to her colleagues. The core of our program were our peer recovery specialists that were hired to become a part of the medical team. They provided patient engagement by facilitating communication between the patient and the ID care team. They engaged patients by identifying their personal goals and supporting patients to achieve those personal goals by supporting them in their substance use and ID care. They also led weekly recovery support group meetings. In addition, the whole program was monitored through a weekly team meeting, which was attended by the peer recovery specialists, an addiction psychiatrist, and the clinician champion that discussed the cases and ongoing plans for care. We recruited participants who received care between January 2019 and August 21. Our outcomes are measured based on patient-reported surveys, and then HIV and hepatitis C outcomes reported from EMR record abstraction. We used paired sample tests and McNemar's tests to compare outcomes at 6 months to outcomes at baseline. Overall, we had 137 patients who consented to have their data used in the study. They were predominantly male, average age of 52, and predominantly Black. Majority came to the clinic for HIV care. About a quarter were receiving only hepatitis C or hepatitis B care, and a small proportion were receiving other ID care. When you look at our outcomes at 6 months compared to baseline, you see that overall there were significant reductions in proportion of patients reporting injection drug use, opioid use, cocaine use, or alcohol use in the preceding 30 days. We also see significant reductions in overdose in the past days, dropping from 13.5% at baseline to 2.4% at follow-up. We also see significant reductions in harmful levels of alcohol use. When we focus on mental health outcomes, we see significant reductions in levels of anxiety consistent with moderate anxiety, no difference in depression, but we see significant reductions in healthcare utilization, including reductions in ED visits in the prior 30 days and reductions in hospitalization in the prior 30 days. Our HIV outcomes are most exciting because at 6 months we see significant increases in HIV viral suppression and significant increases in an undetectable HCV RNA consistent with care. Overall, the RESTORE model successfully integrated low-threshold substance use disorder care into an outpatient infectious disease care setting. Our model was found to be effective for improving substance use, mental health, healthcare utilization, and infectious disease outcomes. Thank you.
Thank you very much. It's time for a very brief question, if anybody does have one. Otherwise, just a very brief question from me, if that's right. Really impressive data. I wondered how you've used this to advocate for a more peer-led approach to be invested in at Hopkins.
So we have been very successful, and the clinic was so excited about these outcomes that we now have a fully funded position for a peer as a part of our medical team who is recognized as one of the most impactful members of our clinical team at Hopkins.
That's great work. Our next speaker is Dr. Jorge Antonio Valencia La Rosa. Dr. Valencia works in clinical trials of infectious diseases. He's involved in research regarding bacterial and viral infections occurring in PWID, homeless people, and other vulnerable groups. His areas of interest are new models of screening, care, and treatment delivery of HIV and viral hepatitis in vulnerable populations. Go ahead.
Thank you for accepting my work. These are my acknowledge and my disclosure. As introduction, I will have to say that traditionally the management of sexually transmitted infection in female sex workers is carried out by laboratory-based diagnosis and treated at healthcare center in Madrid, Spain. All of you know the STI care service need to engage individuals as early as possible, link them to treatment and retain in care. But female sex workers face structural barriers to access accessible and affordable STIs, diagnosis tests, and treatment. Therefore, we decided a short study during a week for street-based female sex workers recruited in the periphery of Madrid, Spain, in a well-known place of prostitution in Madrid, to undergo point-of-care STI screening at a mobile unit. Urine samples were analyzed using real-time PCR for chlamydia, Neisseria gonorrhoeae, and trichomona. All samples were obtained at the moment to enter the study and transferred to a cartridge and finally inserted in the gene expert machine. The results were delivered after processing in 90 minutes for one cartridge chlamydia and gonorrhea and around 40 minutes for trichomona. All participants were offered the result prescribed by a doctor and administered by a nurse in a mobile unit, and all treatments were free of cost. This is our result. The cohort was 49 participants, and the table was stratified by drug use or no drug use. We found only 4 participants were aware of PrEP, pre-exposure prophylaxis, but none of them were on PrEP. The consumption of drugs were more frequent among female sex workers from Spain, in homeless, and those with only primary education. In addition, physical or sexual violence was self-reported more frequently in female sex workers who use drugs. 3 participants self-reported HIV diagnosis, and all of them on antiretrovirals. 7 had HIV antibodies in the rapid test, and 3 of them had viremia. All participants in the follow-up received HIV treatment. The main results were the following. We found high prevalence of each of the STIs, and were more frequent in female sex workers who use drugs. In the multivariate analysis, the unique factor associated with the diagnosis of at least STI was the consumption of drugs. This graph shows the prevalence stratified by symptoms or no symptoms. In the cohort, all participants except 1 received treatment based on the results. As conclusion, the prevalence of chlamydia, gonorrhea, and trichomona and syphilis is high and higher among street-based female sex workers who report the use of recreational drugs, cocaine and heroin. The screening of chlamydia, gonorrhea, and trichomona with a PCR followed by same-day result-based treatment at a mobile unit can engage hard-to-reach female sex workers in care, reduce the transmission of STI in the community, and can help identify candidates to pre-exposition prophylaxis for HIV. Finally, I must to say this strategy was implemented in the harm reduction setting in a mobile unit. And the time is over.
Thanks so much, Dr. Valencia. That was really, really fascinating. I'm sure there are a lot of questions for you. We're running a bit behind time, so we want to ask questions. And actually, sorry, there's one at the mic. Let's take one at the mic.
Like super quick, just practically, on outreach, where did you get people to pass urine? And secondly, did you consider doing swabs in other anatomical locations, such as the throat or the rectum, if relevant?
Well, repeat the question,
Sorry.
please.
Where did the people pass urine on outreach? Did you have a toilet? Secondly, did you think about doing tests elsewhere, such as the throat or the rectum?
Okay. The same question. Women were collect the sample in the periphery of on the street, or invited to enter the mobile unit in the private room. And the second question was
Other sites, screening of the throat. or the
yes,
rectum.
it's a main handicap of the study because the sample was only for urine indicated to vaginal discharge. Yes.
Our next speaker is Miss Caitlin McLeod. Is Caitlin? Hi, Caitlin. So Caitlin is a vascular surgery registrar in Dundee who's undertaking an MD focused on the health impact of injecting drug use locally. In vascular surgery, they don't commonly manage severe life and limb-threatening complications of injecting drug use, but the work that Caitlin's going to present today aims to highlight these health sequelae and develop targeted harm reduction strategies.
Thank you very much. So, just as was said, the perspective that this work really comes from is the fact that what we generally do see in vascular surgery is the more immediate extreme complications of injecting drug use, so the life and limb-threatening complications. And we believe this population is a particularly high-risk group of substance users, and in order to improve outcomes and reduce future harm, we need to understand this population and highlight them, and that's what we're aiming to do. So we know Scotland's in the midst of a drug deaths crisis at the moment, and at the epicentre of that is the city of Dundee. So Dundee has not only got the highest drug-related death rates, but it's also sustained the largest increase in drug deaths over the past 20 years. And the thing is, underlying these drug deaths is morbidity. It's complications of injecting drug use, so whether that's injecting-related infections, injecting-related injuries. And that's what we particularly want to look at. And to capture the population that we typically see, we wanted to look at the limb-related complications, and we did that through looking at discharge codes and also our own vascular surgery operative database over a 9-year period from December 2011 to December 2020. So we found that there were 805 admissions for 465 patients, so there were recurrent admissions for these patients or recurrent opportunities. They're a relatively young population, they're mostly males. 70% went to surgical specialties. Of these surgical specialties, vascular surgery represented 72% of the surgical specialties, and half of all of admissions, 805, went to vascular surgery. And this graph just shows the spectrum really of presentations that we got. So from collections of pus in the groin, which isn't surprising, it was the most common presentation, collections of pus elsewhere in the body, a burst blood vessel, varying severity of soft tissue infections, and clots in the blood vessels. These first 4 presentations, if I can circle them, are the ones most likely to take you to theatre, to the operating theatre. We found about half of all admissions required surgical intervention of some sort, and the spectrum again is shown in the graph. So again, unsurprisingly, most common, drainage of pus, or taking away bad infected tissue was the most common operation, followed by tying off blood vessels, and then major lower limb amputations, of which above knee amputations was most common. And I just want to pause on that. Although that wasn't the most common operation, that's a significant life-changing event in someone who is a young person. And I also want to highlight that only a quarter of these patients who are young and who would be expected to progress to being fitted with a prosthetic limb progress to that stage. None of these patients actually died in hospital, but at follow-up for this population, 21.8% of them were dead. They're young, and they're mostly male. So really with this work, what I want to highlight is the range of limb-related complications people are admitted to hospital with, recurrently sometimes. This is potentially an opportunity for us to intervene and try and reduce future harm. The other thing is there's quite a high surgical workload, both in terms of admissions and also operations. And then finally, these can be quite complex patients to manage with multiple needs, and they tend to have poor outcomes. So really, I think we have to better understand these populations, also highlight secondary care or identify effective strategies in secondary care to try and intervene and reduce future harm, as I said. So thank you very much for listening.
Thank you, Caitlin. Are there any questions, either through the app or at the mics? Just whilst people are thinking of their questions, Caitlin, I wondered if... sorry. Do you want to please...
Hi, I'm Louise from Hep See You Later. Great presentation, Caitlin. Can I just ask, what training is available for accident and emergencies departments? Because there's somebody that was left with a broken hip because somebody discriminated against me and missed it. I ended up with osteomyelitis. I have reoccurring cellulitis, blah-de-blah-de-blah. You know, and the A&E, you know, I was honest about my drug use because I have some morals and values and knew heroin would be masking pain.
Yeah.
But when you're told that you wouldn't have any problem scoring your drugs and other discriminatory language and stigma, it's no wonder people are dying from this kind of stuff. So I just wondered what universal training programs are available, really.
Yeah. And I think that's a really good question, and I think there's probably is, well, certainly my experience, so this is more from a vascular surgery point of view, but there's not really much training for, and there is a lot of stigma, like you've pointed out. I think that's one of the things that we kind of need to unpick, and I think, so I've been thinking about it again from kind of medical point of view, but I think really it starts from back at university. There needs to be a bit more emphasis on this as an issue. And then it comes through to when you're starting as a junior doctor. So people are on the wards, having been a junior on the wards, sometimes we are a little bit uncertain about what we do for analgesia when people do come in, when they do use drugs. And there's a bit of kind of trepidation and a bit of uncertainty. And I think we need better training around all these sorts of areas and the different sorts of complications, because there are some hidden complications that people don't really realise, like the osteomyelitis. It can be a bit insidious. So yeah, you're absolutely right. Yeah.
Thank you very much, Caitlin. And that brings us to the close at the end of this session. So from Matt and myself, thank you very much to all the speakers for a brilliant set of presentations, to the audience. Great questions. And just to remind you that the INHSU Cinema is in the exhibition hall. It's open throughout the conference. Please do go and pick up some headphones. And it really is a great series of short films. There are also poster tours taking place in the exhibition hall at 3:40 today. And again, you can grab a headset from near the INHSU Cinema. Thanks, everyone.
Thank you, everyone.